Point-of-care ultrasound of the heart allows for rapid assessment of cardiac structure and, more importantly, function. The technique involves 4 different views that should be done in the following order, starting from least to most difficult. The subxiphoid view, parasternal long-axis view, parasternal short-axis view, and apical 4-chamber view. This is a good order to acquire scanning competency as well, as the first exams are the most clinically useful. The subxiphoid view of the heart is also the first step in a FAST exam. This video assumes that you've covered this material and picks up after the subxiphoid scan has been completed. Once you've examined the heart for pericardial effusion from a subxiphoid view, the next step in a cardiac ultrasound is the parasternal long-axis view. Here's the image we want to achieve. In this image, you can see the left ventricle, the mitral and aortic valves, the right ventricle, aorta, and left atrium. First, select the probe. Your first choice should be the phased array or cardiac probe. If this probe is unavailable, use a curved array or abdominal probe. Also, make sure to set the ultrasound machine to the general cardiac preset. Position the patient in left lateral decubitus if possible with their left arm extended out of the way. Place the probe to the left of the sternum in the 3rd or 4th intercostal space. If your machine shows the image marker on the left side of the screen, which is the radiology convention, orient the probe marker to the patient right. Most point-of-care ultrasound users and this video follow this convention. Next, find the best window into the heart. This may be up or down 1 or 2 rib spaces. You may also need to slide laterally away from the sternum. Once you see the heart, optimize the image. In an optimal parasternal long-axis view, the mitral valve leaflets should be seen mid-screen. The left ventricular apex is not visualized. If the LV is quite vertical, try moving the transducer up a rib space to make it more horizontal. Use a rocking motion to center the image. The parasternal long-axis view can be used to assess gross LV systolic function, pericardial effusions, and chamber sizes. When assessing for gross LV function, categorize the LV function into hyperdynamic, grossly normal, moderate systolic dysfunction, and severe systolic dysfunction. Estimating systolic function is subjective and requires some experience. However, with practice, you will be able to quickly obtain a gross estimate of cardiac contractility. To do so, consider the following features. First, the change in LV chamber diameter with contraction, and second, septal slap. Observe the motion of the mitral valve leaflet swinging towards the septum. A normal septal slap should appear to touch or nearly touch the interventricular septum. If it appears to come no more than 1 centimeter to the septum, suspect systolic dysfunction. Severe systolic dysfunction can lead to 2 or more centimeters of separation. Most POCUS users eyeball this and estimate, if necessary, by using the ruler on the side of the screen. A pericardial effusion will appear as an anechoic stripe. Clinically significant effusions are usually circumferential. It's important to differentiate pericardial effusions from left-sided pleural effusions. Both may abut against the heart, however a pericardial effusion will appear between the aorta and the heart, while a pleural effusion will appear below the aorta on the screen. A gross assessment of cardiac chamber size can be made with this view. Checking for left atrium, aortic root, and right ventricular enlargement can be made by comparing the relative sizes of these chambers to one another. Commonly referred to as the rule of thirds, the AP diameter of these chambers should approximate a 1:1:1 ratio. If one appears much larger than the others, it may be enlarged. Once you've achieved competency with the parasternal long-axis view of the heart, the next one to learn is the parasternal short-axis. In this image, you can see both the left ventricle and the right ventricle with the septum dividing them. To acquire this view from the parasternal long view, slowly rotate the probe counterclockwise 90 degrees, aiming the probe indicator towards the patient's right elbow. Continue rotating until the left ventricle has a donut shape. Find the papillary muscles at the level of the mid-ventricle. This is the best site to assess LV function. If you see the characteristic fish mouth appearance of the mitral valve, you are too cephalad. Slide the probe towards the apex to find the papillary muscles. The parasternal short-axis view adds the ability to assess for increased RV pressure and offers another view to check for LV systolic function and pericardial effusions. Normally, the LV is circular. Increased RV pressure will cause flattening of the interventricular septum, and the LV cavity takes on a characteristic D shape. Assessing LV systolic function is best done at the papillary muscle level. Normal LV systolic function is characterized by significant shortening of the LV diameter, as well as the presence or absence of thickening of the myocardium during systole. Pericardial effusions can be seen as an anechoic region surrounding and outlining the heart. Once you've completed your cardiac assessment from a parasternal short-axis view, you're ready to move on to the apical four-chamber view. This is an image of what we're trying to achieve. In this image, you can see the four chambers of the heart, the left atrium emptying into the left ventricle, and the right atrium emptying into the right ventricle. Begin by placing the transducer in the cardiac apex area. This is often just inferior and lateral to the nipple in men, or at the base of the left breast in women. Aim the ultrasound beam towards the right axilla. Rotate and sweep the transducer with small probe movements as necessary to obtain an ideal view. If the septum is at an angle, slide or rock the transducer until it becomes vertical. Usually the apex is to the right of the screen, so the correction is to slide laterally. The apical four-chamber view is the ideal view to assess relative chamber sizes and can also demonstrate pericardial effusions and LV systolic function. The right ventricle is normally about 2/3 the size of the left ventricle. Moderate RV enlargement is suggested when the two ventricles are the same size. An RV that is clearly larger than the LV is suggestive of RV dilatation. The intraventricular septum may also bow into the RV, which is never a normal finding. Pericardial effusions can also be visualized from this view, as seen here. Although LV systolic function can be viewed in an apical four-chamber view, it should be used primarily as an adjunct with the other views. Always confirm findings in more than one view. This will decrease the chances of misinterpretation. Stay within your comfort zone. Spend your time acquiring skills in one view before moving on to other views. Don't interpret off-axis images, as this will lead to misinterpretation. When assessing LV systolic function, consider multiple features of LV systolic assessment and check at least two views. Every patient is different. The suggested probe positions and orientations are simply a place to start. Memorize what the heart should look like in each of the views and adjust the transducer placement to achieve that. The best views are obtained by bringing the heart close to the transducer and avoiding obstacles. Make small adjustments to your probe position. Placing a patient into the left lateral decubitus position can often improve a difficult parasternal or apical view. Gentle compression into the rib space can improve contact and allow better beam penetration. Remember that cardiac views are difficult to generate at the best of times. Less than ideal images are not uncommon. However, it's always worth looking, as you can't predict who will be difficult to scan. Exercise caution when using ultrasound for cardiac assessment. Obtaining and interpreting cardiac images is one of the most difficult point-of-care skills. Obtaining a good quality image is challenging. Give yourself plenty of time to practice this skill before incorporating cardiac scanning into your clinical practice.